thank you so much for the introduction, and I'm very pleased to be here to talk about today the future of antiretroviral therapy. So there are my disclosures. So why is there a future? Well, first of all, there seems to be much less interest now in once-daily drugs. And people are looking at strategies for long-acting therapy, and even now, if you take oral therapy, to have weekly tablets. Long-acting injectables, we're now looking for injectables that you can take at least at 3 months, but most of us would like them to be 6 monthly. And subcutaneous injections that we've seen with some drugs now being developed, the problem is if you have large volumes of drug, they're more difficult. But the goal in the end is that patients will be able to inject themselves. Broadly neutralizing antibodies, well, they're looking for a place, and I will cover that today. There are lots of promising compounds which are coming in the pipeline for 2025, but cost continues to be a challenge. And really, we all have to be advocates for low-price antiretrovirals. And finally, I am going to cover about equity of access, because the problem is a lot of these new drugs are only available in some countries. So let's start. What's available now? Well, in terms of single tablets, there are 10 of them available globally. But if you look here, most of the world has TLD. I don't know why this company have labeled it LTD, but it's TLD. Most of the world are on one pill, and they don't have access to most of the others. And you can look at these and tick off the ones that are available in Brazil. Okay, so it's a very interesting market. Now, will the future, and this is something that I've been thinking quite a lot about, will the future still include integrase inhibitors? And I say that because we're now seeing the rise of integrase resistance. So please don't panic, because it's not great. It's probably on a population scale less than 1%. But what we need to do is to keep good surveillance. And if you don't have surveillance in your country about integrase resistance, then you won't realize what's happening until problems occur. Now, I think the future's going to be dominated, and you can see that, and from my presentation, it will be dominated by long-acting formulations. And really the things that we're doing now are long-acting injections and long-acting orals. There's lots of other ways of giving drugs. Okay, we know about the vaginal ring for PrEP, okay, but lots of other ways of giving drugs are on their way. And here's the current long-acting treatments that are available in some countries. And I've just summarized the studies that these drugs have undergone. So you can see cabrolpivirine in naive or switch patients, lots of different studies. And now there are studies going on in those people which we call adherence challenge. In other words, those who keep getting virological failure, can't stick to their drugs, can't take their therapies. And in lenacapavir, the other drug here, it's a capsid inhibitor. A lot of trials have been done in people with very resistant HIV because it's a novel class of compound. And now there are other trials where they've been mixing lenacapavir with standard drugs. So let's look at the future use of a current long-acting drug, cabotegravir rilpivirine LA, the injectable. Most of us give it 2 monthly at the moment. So in the near future, one of the things that excluded patients from having this drug was if they had clade A1. There was early data suggesting that patients with clade A1 would have a higher rate of virological failure, but actually it doesn't look like that's the case. I'll show you why in a minute. And so we are now allowing patients with clade 1. Let me say, getting the clade of a patient is very difficult, right? So we didn't automatically get a subclade before. We just used to get clade A. And now we're having to ask the laboratory to tell us which subclade it is, which subtype. Also, if you give long-acting cabrolpivirine, the recommendation is you should be doing the viral load every 2 months. Again, I think it's going to disappear, and we'll monitor every 6 months. The use in populations with adherence challenges was not allowed at one time or not recommended, but now with some of the new data, even the guidelines are saying that some of these patients could take that therapy. I don't think subcutaneous or thigh injections with the current formulation are going to work. We've seen data in both of these. The subcutaneous doesn't really work very well, or the thigh, because of lots of side effects and problems. The other thing is, how important is baseline resistance to giving these drugs? Now, some of these statements I've given is based on the CARES study, which was cabrolpivir in Africa. And let me say, they did a public health approach. So they only monitored every 24 weeks, not every 2 months. What they did was they randomized people who were virologically suppressed on oral therapy to long-acting injectables or to continue their oral therapy, which was mainly dolutegravir or efavirenz plus nucleosides. And so when you look at the baseline characteristics, imagine if you had all this data, especially in my country, about to start LA. Right, so let's just go through. 58% female, great. BMI greater than 30. It's a relative contraindication to giving this injectable, but we use long needles now for those people with a big BMI. Okay, 57% subtype A1. We'd have excluded these two. 74% with prior NNRTI exposure. We'd be very cautious about this in case they'd failed. But look at this. By proviral DNA, 10% had rilpivirine resistance and 8% CAB resistance. We're doing proviral DNA on these patients before giving them because they're suppressed and we might not have any other resistance tests. We'd have excluded a lot of these patients. But look what happened. In spite of this, 97%. And only one patient on cabrolpivir with virological failure, which we see that sort of rate in the clinical trials. So let me say, it's very effective. You can do monitoring every 6 months. You can include A1. And basically, if ordinary sequencing, standard sequencing showed resistance, we wouldn't give it. But actually, we're doubting whether or not proviral DNA testing is of any use at all, because look at this. Okay, it shows a lot of resistance, yet patients have responded. Now, what about people with barriers to resistance? Well, again, people were very cautious about giving this to people who had problems. And actually, if you decide to give this, this is what this study did. Now, let me say, this is very difficult to do in my country, and I'm sure in Brazil. First of all, you give them economic incentives, and they got about $500, $600 each, right? It's a lot of money. And they had to become undetectable. So when you see the data here, remember there was a step where people were incentivized, and then they were randomized to the injectable or to continue. Okay, so what happened? Well, if you look here, treatment failure was much less in the injectables compared with carrying on. Virological failure, and most of these patients who failed on the injectables actually basically stopped their drug because, look, only 7% virological failure and 10% because of treatment problems, okay? So I've got the data here. And treatment discontinuation, about 21%. But the DSMB, they stopped this early. Not because of the primary endpoints. The primary endpoints showed no difference. It was all the secondary endpoints about tolerability and about people being able to continue and about other things. So it's very interesting. And in fact, 2 of the patients who were given cabrolpivir had resistance. So it is interesting. It's a way forward for some people who find adherence difficult. But as I say, we would struggle being able to give financial incentives and a lot of social support. So what about the real far future use of this? So that in the distant future, we have new formulations. We've got new dosing schedules. And oh, I've got new formulations twice there. Sorry. Okay. So what they're working on at the moment is cabotegravir ultra-long acting. Now remember, if you're going to give cabrilpivirine, you need cabotegravir ultra-long-acting and rilpivirine ultra-long-acting, so probably this will be partnered with something different. Okay. And basically the data shows that if you use these formulations of ultra-long-acting, even subcutaneous here, you can get very good levels all along here, right? You can get excellent. And here's a standard IM doses here. That's 1,200 milligrams here. So it looks like the new formulations might be given for every 4 months. And that's what they're thinking of doing now. And the subcutaneous evaluation is ongoing. There's also this other way of injecting it into, like an implant, a small biodegradable polymer. And you put it inside, and it releases the drug slowly, slowly, slowly. And they've found that you can get plasma concentrations for almost a year, almost. So there we go. There's, again, I think both of these look like PrEP agents more than treatment agents, but if they can find a partner with them that can last the same way, you would use them in treatment. There's also a CAB Pro drug, which is there's 2 of them now, which can be given by subcutaneous injection. And why is subcutaneous injection so important in this world? It's because a patient can give it themselves. You can have a device that's all prepackaged. You just take it out, put it there, and you're done. So that's why people are moving away from intramuscular injections. We have special clinics set up to give intramuscular injections, but it would be much better if people could do this in their own home and just come in every 6 months for testing. What about lenacapavir? This is a capsid inhibitor. It's approved at the moment for heavily treated, experienced patients. But interestingly, it's given every 6 months subcutaneously. And it's given in the clinic because you have to give it just right. Otherwise, if you put it in wrong, it can cause painful nodules. It usually does cause nodules. And they can even ulcerate, and the absorption can be wrong. So you have to get that right, and you can take it orally. So oral lenacapavir is also available. And in the near future, I think it's going to be given with cabotegravir, but also, interestingly, with bictegravir, but as oral, because you can't give bictegravir injections, of course. So let's look at LA-CAB. And len subcutaneously, plus or minus rilpivirine. And there's just a case series of 34 patients. And the virological suppression, at baseline only 47% were, but when they switched to CAB-LEN, you can see here they got very good results. So it looks like that CAB and LEN together might be a good option. The problem is that one's given every 6 months and the other given every 2 months, so you have to just plan the way the injections are given. And I think sometimes the companies say, we don't like that there's a difference. But actually, in terms of managing patients, I think that it's not a big problem to overcome. However, let's see what the future of that is. Now, what about giving lenacapavir with current antiretrovirals? Now, this is the first time we've ever seen bictegravir on its own, because all bictegravir is co-formulated. It's not given on its own. So this time, we've been saying, could we have it, please, on its own so we can use it with other drugs? But it's not been available. But now here in this trial, they used bictegravir with lenacapavir. And they used 2 doses of lenacapavir, 25 milligrams. Now, this is oral daily, and here again, 75 oral daily versus continuing the baseline. And when you look at this at week 24, okay, these people remain suppressed, almost all here, okay. And you always see a little bit in new drugs, in people who switch, a little % or 2 who stop the drug because of side effects. Whereas you can see these people, they've been on this drug before, and they're just continuing on it, so they don't have side effects from it. So now they're moving forward into phase 3, and they are trying to develop a long-acting bictegravir. So imagine, I mean, companies always like to keep everything in their own place, right? They don't want to share with other companies much. So Len and Bic, both from Gilead, would be the sort of obvious choice for them. In the distant future, there's a novel oral prodrug of len that you take, and it basically is very stable, and it's converted into lenacapavir. And it can be long-acting. So let's see how that goes in the distant future, whether or not we'll have oral long-acting lenacapavir. And here's some of the data on the prodrug, and you can see the levels are out for over a month here, and this was given every 6 weeks. So you can see 6 weekly would be a bit difficult, so it would end up being a monthly therapy. Islatravir, and you know islatravir had a problem. We had a problem because of lymphopenia, and so the monthly oral formulation, because it was such a big dose, and that's the problem, it was dose-related, the lymphopenia has been stopped, and now people are experimenting with islatravir plus doravirine, of course, because both of these are Merck drugs, or islatravir as a standalone agent. And here's their phases if you want to have a look, and you can see that they're looking at injectables and also an islatravir prodrug for the long-acting, and weekly oral as well with lenacapavir and with this other NNRTI 8507. Just quickly, islatravir and doravirine versus doravirine 3-TC-TDF. We call that Delstrigo where we are, and you can see that whether you take islatravir at low dose or 0.75 or 2.25, all of these different doses, you get pretty good virological response. This was a bit less with that, but there's no real statistics in here because the numbers are relatively small. And so that is something that people are thinking about, islatravir plus doravirine daily oral. So. But there were 6 people with protocol-defined virological failure, and that's a bit concerning, actually, with drugs like doravirine, which may have a slightly less genetic barrier, and so we just have to be thoughtful about whether or not, this is something that's going to compete with other therapies. Oral weekly now, islatravir and lenacapavir. Isn't that interesting? We got weekly tablets coming out, and basically you get randomized to weekly oral islatravir and lenacapavir or continue BF-TAF. And if you look here, they both did extremely well. The lymphocyte count did not go down. They didn't have any real major adverse events due to any lymphocyte problems. And you can see again a weekly pill with islatravir and lenacapavir. And where's islatravir going? Well, there's subdermal implants being developed which wash out the drug slowly. And it may be that we'll get 6 monthly or even longer from these subdermal implants. And that's very interesting. And also, they're developing microneedle patches. I think Merck have got a big history of developing devices and things to deliver their drugs. And this may be 3 monthly, 6 monthly, or even 1 year administration. I've just put the data here. You don't need to look at that. It's just to say that subdermal implants and microneedle patches are on their way with islatravir in terms of experimentation. I'm now going to switch gears a little and just talk a little bit about broadly neutralizing antibodies. What are they? Well, they neutralize infection. They bind to the HIV trimer, and they can neutralize multiple strains of HIV. But as I said yesterday in another talk, I think that they have issues. So in treatment, CROI this year was full of BNABs. So we call them BNABs, and mostly with similar results. First of all, you have to do screening of the patient to see whether or not their virus is going to be susceptible. So that's technology, and that can be difficult. There's a high proportion, up to 50% of these patients fail due to pre-existing drug resistance to these compounds. It's really difficult. You've got to demonstrate that they should be active before giving to them. You don't want to give drugs that aren't. And even people with HIV with susceptible virus and had good levels, the results still aren't as good as standard triple therapy. There's more virological failures with resistance, and obviously a lot of them still require intravenous administration. So if I say go back to your clinic and give something you've got to do a test for to check whether it works, and you've got to give it intravenously, it suddenly is a burden. And you have a higher risk of failure with the resistance. You suddenly get to a situation where you're thinking, at the moment, maybe they're not there. So, I just wanted to note, so they gave single monoclonals, they give them in 2 monoclonals, 3 monoclonals, or single that had 3 activities on the binding site, and all of them showed this sort of issue. So what else have they been doing with BNAbs? They've been combining them with antiretroviral therapy. So they're looking at them like an antiviral in itself to be combined with a long-acting. And there have been 2 studies that were presented, one with lenacapavir and one with cabotegravir, our 2 common long-acting drugs. So let's look at the first one. So this is lenacapavir plus BNAbs, and there is a prize for anyone who can pronounce these drugs without reading them. All right, so we call them TAB and ZAB. They're 2 monoclonal antibodies that bind to the CD4 binding site of GP120 and the V3 glycan of the envelope. So now, they had a study before where you had to be susceptible to both of these BNAbs, and they had very good results with up to 90% working. When they looked at this study, you had to be susceptible to one or the other, and very few of them were susceptible to both. So what did they find? Well, they found actually that you can see here there are 2 doses of ZAB, 10 and 30, and in the lower dose of the monoclonal, you got more people with greater than 50 copies. Okay. So it looked like you need to give a higher dose of the ZAB to be able to overcome virological failure. And when people have been asked about monoclonals, specialists in this area, they say that probably you need more than 1 monoclonal, probably 3, and this is mainly in PrEP, and also that the doses needed need to be high. So we've now got a problem with intravenous injection, testing before you give them to make sure you're susceptible, maybe giving more than 1 that you're susceptible to, as well as making sure the doses are high. So they're all challenges for monoclonals going forward, for BNAbs. There's a CAB-LA plus BNAbs. There were 71 virally suppressed patients. Now, they gave monthly cabotegravir. I mean, we would now give 2 monthly, but in the US at one time it was monthly, plus twice monthly BNAb, this VRC07. And 66 out of 71 patients suppressed. And you can see that they said, oh, people got viremic because they had vaccines before. Fine, that is a reason. But one of them did fail with a cabotegravir mutation. So again, it's early studies. So the limitations, I've just gone through all of those. Primary resistance testing, how many do you need? Higher doses. And also, they don't tend to penetrate well in anatomical reservoirs. So as I've put here, not ready, I don't think, for prime time. The future direction is they're making all these bispecific and trispecific antibodies. So one antibody will bind to several sites. Also, they're trying to make them not only bind to the CD4 receptor, but also to co-receptors. So you've got a sort of Maraviroc-style effect from the BNAbs, and also use other classes, because they're all IgG1, these BNAbs. And now imagine having an IgA or IgM that might be mucosal protective, etc. And the last thing is that they're also thinking about using mRNA technology. So what you do, you encode lots of different BNAbs in mRNA, you put it into like a vaccine into your arm, and that produces the vaccine, the BNAbs itself. Okay, so you really program your body to produce them rather than have them injected into you. Now, of course, let's see how that goes. All very interesting. Final bit is new drugs. Now, you'll be very happy I'm not going to go through each of these new drugs and show you all the studies and all the slides, because in my experience, and probably in yours, out of all of these new drugs, probably only one, maybe two will finally get to phase 3. But just to show you, I've just summarized them all. First of all, you'd think it's all going to be integrase, but it's not. You can see here that there are these NRTTIs. That's a bit like islatravir, all right, oral weekly or monthly. And see, these 3 are oral, and the one, this maturation inhibitor as well, is oral. So it's not all going to be injection. And here are the integrases here, and this one, oral weekly integrase, together with all these injectables. There's an unboosted PI coming, which may be just daily. Now, why do you want that? Well, imagine that you've got a lot of resistance and an MDR HIV, then an oral protease without a booster would be useful, because you've got no booster causing problems with other drugs. And then more capsid inhibitors are on their way, but they've got relatively shortish half-life, so they might be weekly or monthly. So this is just a summary of new drugs on the horizon. And as I say, I don't know how many of these will end up going past phase 2, but let's see. So I just wanted to finish with a very interesting concept that you will see more of in the future, because people are working on this. This is called target activator of cell kill. Now, what happens is that, interestingly, some non-nucleosides. Now, imagine we thought we got rid of non-nucleosides, that they were very, we got rid of ephedrins. We use a lot of doravirine because it's a very useful drug with no drug interactions, really, and very well tolerated. But the world, WHO and the world, have turned to integrase. But imagine now, look at this, some non-nucleosides, they interfere with late-stage viral replication, just here. Here it is. There's late stage where the virus is budding off. You can see that. So non-nuclear, some of them interfere just here. And what they do, they promote this HIV protease activation inside the cell. Now, usually this happens in the maturing budding virion here, the maturing budding virion. But these drugs, these non-nucleosides, are having an additional effect before the virion starts to mature and starts to bud off. And then the cell recognizes something's happening here, right? We've now got a problem with protease activation outside of the capsule of the virion. So the cell can now recognize something is happening, and the cell dies by pyroptosis. So imagine now you have a drug that is not only a non-nucleoside, but it's also having effects downstream. And you know with capsid inhibitors, there are various places where they're working. Well, now with non-nucleosides, this target activator of cell kill is something people are looking at for non-nukes. And here is just some data. I don't think the data is fantastic. This is log change in viral load. These are controls. And these are people with, this is a non-TAC NNRTI, like most of the ones we've got. And here's a TAC. And all you can see is that very early on, it's really early on that it's working, getting the viral load down. Whether or not these in the long term will have any impact at all, I don't know. But let's see. It's very good science, I think. And it may be that we could have non-nucleosides back on the agenda because of this. So now I just wanted to change now, just a completely different subject. We've just published this about the long wait for long-acting HIV prevention and treatment formulations. There's really no patent manufacturing or operation expansion plan in place for cabotegravir or rilpivirine worldwide. There's no apparent plan to support large-scale studies of cabotegravir or lenacapavir. I showed you the small study. And basically, what we're saying is WHO, financial donors, and the manufacturers and governments, they need really to coordinate. And in fact, it's very difficult at the moment to think that these long-acting compounds are going to penetrate markets in low and middle-income countries. And that's very sad. And so we hope that people will get together and put pressure. Whatever the manufacturers say they're going to do, we really need to see it in reality. So finally, in conclusion, the future of antiretroviral therapy, the main thing is, I don't think we're all moving to just one therapy. Maybe that will happen, but what will be a good thing about what's going on, it'll give us more choice, including oral treatments. Not everybody wants a patch, an implant. Not everybody wants an injection, right? Some people are very happy taking oral drugs, so that will give us more treatment. Long-acting therapies will have various dosing intervals from weekly to 6 months, whether that's oral weekly or injectables or patches or whatever, 6 monthly. They will have novel ways of administering, and really the goal is to self-administer at home. There's some novel non-integrase combinations, so not everything's going to be integrase being developed. And as I say, global equity is essential if all the world is to benefit. Thank you.